Hello, my name is Dr. Bryan Martin. I'm the president of the World Allergy Organization. And it gives me great pleasure to welcome everyone to the World Allergy Organization's World Allergy Week. The focus for the year 2024 is on food allergies, and the title of today's webinar will be Overcoming Food Allergy Obstacles. Now, the World Allergy Week is a vital part of the World Allergy Organization. And this year we've decided to focus on food allergies because food allergy is a growing global health problem. This can be a life-threatening problem, and we understand that the physician and the patient partnership is essential. All of us who take care of patients with allergic diseases need to understand that food allergy is all around us. It's a shared responsibility. We who treat allergic patients need to know what food allergy is, be able to recognize and elucidate the risks, and be prepared to help our patients who have food allergies. The World Allergy Organization is an international umbrella organization whose members consist of 111 regional and national allergy and clinical immunology societies from around the world. And our mission is to be a global resource and advocate for the field of allergy and immunology, advancing excellence in clinical care through education, research, and training. We form a worldwide alliance of allergy and clinical immunology societies. So the World Allergy Week is an annual education program of the World Allergy Organization that is developed by an international advisory panel. And for this year, our chair is Professor Elham Hasni. So the World Allergy Organization board is made up of 19 individuals from around the world. They are specifically selected to represent all areas of the world so that we have all different viewpoints represented on our board. And if you're a member of an organization that is a part of the World Allergy Organization, then you are an individual member of the World Allergy Organization. And I would like to thank everyone for being here today. The World Allergy Organization also has its own journal. Professor Alessandro Fiocchi, who you will hear from shortly, is the editor-in-chief of the World Allergy Organization Journal. And our deputy editor is Professor Mona Suleiman Alamad from Kuwait. Our next World Allergy Congress, the WAC 2024, will be held in conjunction with the Portuguese Society of Allergy and Immunology in September in Lisbon, Portugal. Our 2025 Congress will be held in conjunction with the American Academy of Allergy, Asthma, and Immunology in San Diego, California, from February 28th to the March 3rd, 2025. So I think that today's webinar will be quite interesting. We have a wonderful lineup of esteemed food allergy experienced researchers and speakers for you today. And that at the end of our presentation, we'll have a discussion and time for questions at that point. So please hold your questions until all of our speakers have completed their talks. Thank you so very much, and welcome to our webinar.
Hello, my name is Karina Venter. I'm an allergy specialist dietitian from Denver, Colorado, where I'm also professor of pediatrics in the section of allergy and immunology at the Children's Hospital Colorado and University of Colorado. I would like to thank the World Allergy Organization for asking me to present on the World Allergy Week on the topic of food allergy definitions and prevalence. And so over the next 10 minutes, we will be looking at the classification of food allergies. We will look at new or updated classification of food allergies. I will look at the prevalence of food allergies across Australia, South Africa, Asia, Europe, the United Kingdom, and United States, and then briefly touch on the time trends in the prevalence of food allergy. So first of all, the definition of food allergy. So the National Institute of Allergy and Infectious Diseases defines a food allergy as an adverse health effect arising from a specific immune response that occurs reproducibly on exposure of a given food. And although I do agree with this definition, I wonder whether it's time to perhaps rethink about this definition when we think about tolerance to baked egg and milk. And so we can actually give a child milk and yogurt and they may have a reaction, but that reproducible reaction will not occur when they have a baked milk or egg product. When we then look at the further definition and nomenclature used for food allergies, we can see here that food allergies are defined or divided into IgE-mediated food allergies or the immediate type food allergies, which occur within 2 hours of ingesting a food. I think most of us doing oral food challenge knows that it normally happens within in minutes rather than hours, although I've seen some later onset symptoms myself. Then we get the food allergies, which are referred to as the non-IgE mediated food allergies. They have more of a delayed onset, typically about 2 hours after ingesting the allergen. Although the first one on here, food protein-induced enterocolitis or FPIES, can occur about an hour after consumption of the food allergen. Then we also have eosinophilic esophagitis, which is the narrowing of the esophagus over time. Food protein-induced proctocolitis, which is the classically blood in the stool. Mild to moderate non-IgE mediated food allergies, under which we can classify symptoms such as gastroesophageal reflux disease. Very hot topic whether eczema should be classified as a mild to moderate non-IgE mediated food allergies. And then we also see enteropathies, which is not often really encountered within the food allergy clinic. So let's look at the new updated definitions of food allergy. So this is a very interesting paper from the European Academy of Allergy and Clinical Immunology, or EACI, where you can see that food allergy, and they don't actually say whether they refer to IgE or non-IgE mediated food allergy, is classified as a type 1 immediate reaction. So one would assume it's IgE mediated food allergies. Then EOE and food allergies, again not specified, are classified as a type 4B, cell-mediated immune response. Finally, we have FPIES, EOE, and celiac disease defined as type 5 epithelial allergic diseases, and no mention of proctocolitis. And so I think to really make this work in clinical practice, we may need to revisit and really look at these definitions and exactly what they mean and what they refer to. But I still think very interesting paper and really telling us that, as everything in food allergy is moving forward, so may the definitions and the nomenclature also need to move forward and be adapted. If we then go on to the food allergy prevalence data, and I'll start with the highest data ever reported from Australia, and this is the HealthNet study from Melbourne, where we saw at 1 year, over 10% of children were diagnosed with an IgE-mediated food allergy using an oral food challenge. At 4 years, the data was about 4%. And then this at school age data coming from the SchoolNut study, where they've used either an oral food challenge or a clinic evaluation with set criteria, about 5% of children between the ages 10 to 14 years of age were diagnosed with a food allergy. I know that those of you who know me may know that I have mentioned this many times. Alongside the children in the Europe-Prevail study, the children in the HealthNut study were fed raw egg during the oral food challenge, and the majority of the 10% was driven here by egg allergy. As you can see at the bottom, about 8.9% of children had an egg allergy. And then very interesting, of those with the raw egg allergy, about 80% could tolerate baked eggs. So perhaps if these children were challenged with boiled egg, which is often used, or a baked egg muffin, these prevalence figures might have been much lower. Then moving on to the very interesting data from South Africa, the South African Food Allergy Study, or the SAFA study. I'm sure you might have seen the very interesting presentations from Mike Levine in the past. I think there's two interesting things we can take from this study. First of all, the food allergies was diagnosed by oral food challenge. Children were about 1 to 3 years of age, and the children in Cape Town, so more in the urban area, had a much higher percentage of food allergy, 2.5%, compared to the children in the rural Eastern Cape, which was 0.5%. As you can see, they did look at the common food allergens such as egg, peanut, cow's milk, soy, wheat, fish, and hazelnut. And what we then can also learn from the study, the second point, is when we looked at the Black Africans, mixed race Africans, and the white Africans, there were different, prevalences in food allergy. You can see not significant, but slightly lower milk allergy in the white African children, and slightly higher egg allergy. Slightly lower any food allergy in the white African children, and slightly higher egg allergy. But again, like I said, this was not significant. So very interesting data, urban versus rural, and then also the ability to look at different races within the same country. If we then go to the next slide, which is data from Asia, and here we have the data from India, children 6 to 11 years of age, which again, I will highlight in my summary slide, the lowest reported rates of food allergy that I'm aware of. In this study, they looked at the number of different food allergens, and you can see many of them were 0. And you can look at the slide again at later reference to look at the different food allergies. But what was interesting, this is the data from Hong Kong, and the 2 cohorts in China and the 1 cohort in Asia was part of the Europe-Revel-INCO study. Food allergy or probable food allergy was diagnosed as reporting allergic symptoms within 2 hours of ingestion of a specific food, plus the presence of allergic sensitization to that food. So this was clinical history plus sensitization. It was significantly higher in Hong Kong, still not too high rates, but significantly higher in Hong Kong, much lower in the China cohorts, and like I said, the lowest in the India cohorts. And this data was also lower than Chinese data previously reported in children 3 to 6 years of age, where the diagnosis was based on an oral food challenge and sensitization data. So what we can learn from this study is that it's perhaps not just location that matters, but age of assessment may also affect, the prevalence data that we see, and perhaps some different foods from different countries. So, and to get to the point of different foods, here we have the data from South and Central America. I reference very many studies here for you on the slide. Most studies use parent proxy or self-report of allergic symptoms. A few studies measured skin prick test, prevalence rates from 0.9 to 52%, which is a big range. Food allergies to similar foods in other parts of the world, but in Mexico, Costa Rica, and Colombia, there was reported sensitization to tropical vegetables and fruit. I know when we go to Costa Rica, my children go on a diet of pineapples and mangoes. In the tropical region of South America, they saw some oral mite syndrome allergies, and there was also increased oral allergy syndrome, or perhaps correctly referred to as pollen food allergy syndrome, in Mexico, and alpha-gal seen in Colombia. Then in Europe, I can't show you all the data from Europe, so I'm referencing here the systematic review we recently published. When we look at food allergy rates for all food allergies, 2000 to 2012 versus 2012 to 2021, there wasn't really an increase in overall food allergy, and there were slight differences between the different types of food allergies in terms of prevalence in the European cohorts. You can see that the tree nut allergies were the highest, with the fish allergy the lowest. In the United Kingdom, this is our data from the Isle of Wight. You can see that by 10 years of age, there was a significant increase in peanut allergy in children born in 1989 versus children born in 2001. Interestingly, when we look at overall food allergy, there was a significant decrease in overall food allergy at 1, at 2, at 3 years of age, and no difference at 10 years of age. And just to remind you, the Isle of Wight birth cohort, children didn't have to be sensitized, but they had to have a reaction within 2 hours or a reported reaction within 2 hours to one of the common food allergens, whereas in the FAIR cohort, the children had to be sensitized, and if they consented, they underwent an oral food challenge. Otherwise, we looked at clinical reported symptoms plus a positive skin prick test. So slight different definitions of food allergy, but I think the most interesting finding from looking at these two cohorts in the same geographic location, that there was a significant increase in peanut allergy. If we then, this data just actually summarize once again what I've showed in the tables for you, but you can see here, very interesting also, that sensitization rates went up in the Isle of Wight. So in the earlier cohort, it was higher, not significantly higher in the 89 cohort than the FAIR cohort at 10, but we saw the opposite when we look at overall food allergy by 10 years of age. When we look at the US data, to just conclude, 8% of children in the US aged 0 to 18 years had a food allergy. The most common food allergens were peanut, milk, shellfish, and tree nuts. 40% of children had allergies to multiple foods. This was all parental reported, and 42% have experienced a severe reaction. And so just really to summarize, as our time is running out, the definitions of food allergy are evolving with the times. Food allergy prevalence differ between countries, ages, and the food studies. Different diagnostic method and definitions of food allergies are used in studies, and perhaps it may be fair to say that the prevalence of food allergy may be as low as 0.14% in 6 to 18 years old children in India, and as high as just over 10% in 1-year-olds in Australia if we take allergies to raw egg into account. And so with that, I would like to thank you for your time.
Dear colleagues, hello. It is my great pleasure to support with the following talk, the World Allergy Week. And this talk is dedicated to clinical aspects and quality of life in food allergy. My name is Margitta Worm. I'm located in Berlin, Germany. Food allergy is an IgE-dependent disease, and after binding the allergen via its IgE and IgE receptor, mast cells can be activated, and the clinical picture might be quite diverse. We can have skin symptoms only, can have respiratory or gastrointestinal symptoms like diarrhea and vomiting. The most severe reaction of an IgE-dependent food allergy is anaphylaxis. The symptoms occur in their frequency in a different manner. The most frequent symptoms we observe are skin symptoms, as mentioned, urticaria, but also angioedema. The less frequent symptoms in IgE-mediated food allergy are the gastrointestinal ones, with a range of below 50% if we look in larger cohorts. The respiratory and/or cardiovascular symptoms are also quite frequent. This is data we obtained in the anaphylaxis registry many years ago. Here again, we see the different organ systems and the frequency of the onset of the different symptoms. And as you can see in the x-axis, we have the different age groups, and on the y-axis, the percentages in terms of onset. And what we can easily see that the onset of symptoms is also depending on the age. In very small children, we more often observe, for example, vomiting, whereas symptoms like cough are decreasing over age. And finally, the cardiovascular symptoms increase in higher age groups. So whenever you see a patient with food allergy, you also need to consider that the onset of symptoms may be related to the age of the affected individuals. So what are the most frequent elicitors of anaphylaxis, food-induced anaphylaxis? This is published. This data we published out of the anaphylaxis registry. As you can see, we do see differences again between children and adults, and the peanuts are the most frequent elicitors in children, followed by cow's milk and hen's egg, whereas in adults, the most frequent elicitors, at least in this cohort, so data from mostly European patients, were wheat and shellfish. The whole cohort of food-induced anaphylaxis was above 3,000 cases. This enabled us to look in more detail in the phenotypes of food-induced anaphylaxis. You see here for cashew, mean age group is 3 years. We do not see so often recurrent reactions, rather see severe reactions. And in this smaller cohort, we were not able to identify a particular risk factor. Different for peanut-induced anaphylaxis here, the mean age group was a little higher, 6 years. 50% of the patients had already repetitive reactions, and these were also rather severe. And as a risk factor for severity, we were able to identify physical exercise. Now have a look into the adult food-induced anaphylaxis, here shown for shellfish. Mean age is 36 years. Approximately 1/3 of the patients have recurrent reactions, and these were not as severe as in the children group, and as a rather protective factor for severity, we identify by statistical analysis rhinitis. Then wheat-induced anaphylaxis, 34 years, also a high rate of recurrent reaction, and here as risk factors besides well-known risk factor physical activity, alcohol consumption was identified, and in comparison also to the shellfish-induced anaphylaxis, the severity was rather high. We do know that many cofactors, at least in adult food allergy, can contribute to the onset of a reaction. We can differentiate these into intrinsic and extrinsic factors. Among the intrinsic factors, we have genetic predisposition, co-diseases, biologic determinants like hormones, age, and PAF level. The extrinsic factors are characterized by physical activity, alcohol, certain drugs, and not to forget psychological burden. This enabled us also to calculate on the relative impact of these risk factors in food-dependent anaphylaxis, and you see here age turned out to be the risk factors with the highest relative impact, followed by exercise and male sex, and not to forget concomitant mastocytosis. Now, the second part of my talk is dedicated to quality of life, and this is what patients quote. 90% is about quality of life and food allergy. So we need to be aware that the impact on quality of life for our patients is high. And this shows a little bit the situation. So as we know, fortunately, food allergic reactions do not occur like every day as in other chronic diseases, but on the other hand, the burden for the patient is given every day. So there is a discrepancy on one hand, the reaction, which fortunately and usually does not occur every day, but the situation for the patient means still that the food allergy is present every day. So what are these factors you see here? This is a review by our group on the impact of food allergy on quality of life, and there are here many factors with a positive influence, like if we make the diagnosis in a patient, or if we perform certain treatment measures, but they are also negative impact. One is about to shop food items, and where it's difficult, in particular also out of restaurants, to find out what the dish is containing, and also the impact in the family and the role of acute reactions, which also, of course, impact quality of life. So in our own data, this is here on tree nut and peanut allergic patients, adult patients, and one measurement for the burden of quality of life is the food allergy questionnaire. And what you see here is the impact on the may contain label on the quality of life, and those patients who consider this label have a significant greater impact on their quality of life. What we can also see that there are sex-specific differences in the impact of quality of life in food allergic patients. So I would like to sum up. I have shown you that food allergy is IgE-dependent disease. It occurs many times in the organ manifestation of the skin, urticaria, angioedema, itch. It can be life-threatening, and for these severe situations, the involvement of the respiratory and/or cardiovascular system is relevant. I have shown you a little bit about the elicitors. These are age-dependent, about the role of cofactors, and last not least, that quality of life is impacted in these affected patients. So I would like to thank you for your attention, and I'm happy to take questions. Thank you.
Welcome to the World Allergy Week 2024. In the next few minutes, I would like to discuss with you some challenges that we meet during interpretation of food allergy diagnostic tests. I have no disclosures. Indeed, an accurate diagnosis of food allergy is essential because underdiagnosis can place the patient at risk of severe allergic reaction. On the other hand, overdiagnosis has its major impact on the quality of life of patients and their families due to dietary restrictions and social limitations. In a study on the over-restrictive elimination of foods in children with food allergy, it was found that at least 50% of physicians would put the nursing mothers and the infants on restrictive diets for at least more than 5 foods, up to more than 10 foods in some cases. This is usually without basis because allergen-specific IgE tests have a high rate of false positives. Sometimes they cannot distinguish true food allergy from just sensitization. So screening panels of food allergens without consideration of the history are not recommended. As you can see from this study, from the overall US pediatric population, at least 28% before the age of 5 years had food sensitizations, and more than 21% from 6 to 19 years. Although actual food allergy was detected in the same population in only 7.6% below the age of 17. If we would like to have a look at the available IgE food allergy tests, of course, oral food challenge is the gold standard with high sensitivity and specificity, but it's stressful, time-intensive, expensive, and carries a risk of allergic reaction. Skin prick test is standardized, fast, and cheap, but more sensitive than specific, carries the risk of false positive reactions. The same goes for allergen-specific IgE. Concerning basophil activation test, it has a high sensitivity and can predict the response to oral immunotherapy, but not standardized in many instances. Mast cell activation test uses plasma, and this makes it more convenient, but it is and has a high specificity but low sensitivity and not standardized as well. Component testing has high specificity and sensitivity, but currently not available for many allergens. It's only available for peanuts usually, and not available in every country. So to summarize, all tests have the capability of identifying food allergens, which I mean sensitization. But not all of them are the gold standard for diagnosis. Sensitivity and for instance, is high for skin prick test and serum-specific IgE, but low specificity and low positive predictive value. Component result diagnostics are midway in terms of sensitivity and high in specificity. Basophil activation test is high in all, but it's not without challenges as well. Oral food challenge is of course the gold standard for the diagnosis with high sensitivity and specificity, but has many disadvantages as well. So we have many diagnostic challenges. On the top of the list comes the misinterpretation of the results of serum-specific IgE. Some physicians consider any detectable level as diagnostic and put their patients onto unnecessary avoidance. Of course, there are higher levels of serum IgE or skin prick test wheel size that would correlate with the probability of having a clinical allergy, but they do not reflect the severity. Cross-reactivity is also an issue. For instance, more than 50% of patients with peanut allergy test positive to other legumes, although only less than 5% have clinical symptoms after ingestion. This sigmoid curve shows a positive correlation between the serum level of serum-specific level for peanut and the clinical probability of clinical reactivity. Not only peanut, but wheel size of skin prick test can identify allergy to egg, peanut, milk, soy, and wheat when there is a large diameter. For instance, we have cutoff values that carry a 95% positive prediction on serum-specific IgE testing. For instance, for cow's milk, 15 units for beyond the infancy, and in the first 2 years of life, 5 units. For eggs, it is 7 after 2 years and 2 before 2 years of age. The 50% negative predictive values are also high, so you cannot depend on the sensitization levels that comes to you from the lab, which is 0.35 and 0.45. These are not enough to diagnose food allergy. Skin prick test wheel size can carry a more than 95% positive predictive value if it is big enough. For instance, for cow's milk, more than 8 millimeter, and in infants, 6 millimeter. For egg beyond infancy, 7 millimeter, and in infants, 4 to 5 millimeters, and so forth. If we compare between serum specific IgE and skin prick test, we will find that both are highly sensitive than specific. But the effect of medications appears more in skin prick test, and this makes an advantage to serum specific IgE, which is not affected by medications or skin status. The time factor makes skin prick test more advantageous because you have the result in 20 minutes and the impression on the patients is dramatic. You have to consider the causes of false negative and false positive skin prick testing. The false negative occurs due to poor potency of extracts, due to some drugs modulating the allergic reaction, including antihistamines, diseases attenuating the skin response, such as leprosy in some countries, improper technique, for instance, weak puncture, and limited local production of specific IgE in some patients. The false positive results happen when there is dermatographism, irritant reactions, or non-specific enhancement from a nearby strong reaction. Concerning component testing, there is also advantages and limitations. Component testing has the advantage of higher specificity. For ARA H2, for peanut, for instance, it can differentiate cross-reactivity from true allergy, but it is limited by the range of the allergens available. And it gives a high false negative results due to testing of a single component. Concerning allergen peptide testing, it has the advantage of having a good diagnostic discrimination, but it detects only sequential epitopes and has a high level of false negative results as well. Basophil activation test and mast cell activation test. Both need flow cytometry and are expensive, not available in every country, but they have a high specificity. Blood collected for basophil activation, it depends on whole blood. So it has to be delivered to the lab within 24 hours. And then after antibody staining for identification of the basophil and activation markers, activation can be measured easily. Mast cell activation test uses plasma, so it's more convenient. You can keep the sample till the time of estimation, and then you perform antibody staining for activation markers measured by flow cytometry as well. They both have advantages and limitations. BAT and MAT have the advantage of being in vitro tests. No risk of allergic reactions, no need of stopping antihistamines or clearing the skin. But the BAT has a higher specificity, sensitivity, and positive predictive and negative predictive values. The limitations of BAT include being depending on whole blood, so it has to be sent to the lab within 24 hours, more expensive than specific IgE or skin prick test, and at least 10 to 15% of persons have non-responding basophils. The MAT provides results if non-responding basophils, but it's more expensive even than basophil activation test and has a lower sensitivity and negative predictive value than the BAT. When you make the decision to do an oral food challenge, you have first to have a good clinical history and go through a well-chosen IgE test to make your decision. We used to have a very simple indications for doing a food challenge. When to do a food challenge: when skin prick test or serum specific IgE is positive but not conclusive, when patient's history suggests reaction to food and the test results are negative, or in cell-mediated reactions after successful elimination. And you don't need to do a food challenge when evaluation makes challenge unnecessary. For instance, convincing history plus highly positive test, or when you have a recent severe systemic reaction or anaphylaxis. In food protein-induced enterocolitis or FPIES, oral food challenge is usually indicated to verify the tolerance rather than to confirm the diagnosis. It is typically done 12 to 18 months after the last reaction, and you expect a reaction within 1 to 4 hours of ingestion. Intravenous fluid resuscitation is unnecessary usually, and admission to the emergency department or ICU are not needed. Even in infants, it was found that the oral food challenge carries a lower risk than older ages of reactions, and the use of epinephrine was lower as well. So the limitations of oral food challenge include resources that are not available in every center. It needs highly skilled and trained clinical team. Ideal conditions that we perform the oral food challenge in are different from the real life allergic reactions. Of course, an anxiety and need for standardized food-specific dosing schedule are other challenges, and there is no absolute accuracy. There are factors that would influence your decision to perform an oral food challenge. The indications are lower when you have a history of an allergic reaction or recent exposure to the food, and when the resources are not available. And the indications are higher when there is a low specific IgE level or the food is important to introduce into the diet. Of course, patient preference is an issue to be considered before making this decision. So this flow chart would summarize a proposal for the indications of oral food challenge. First, you do a good history and then perform skin prick testing or specific IgE. If the results, the first step, this is the first step, if the results are negative, it's likely tolerant. If the results are positive with a higher positive predictive value, then the patient is likely allergic. If the results are equivocal, then the next step, if you have component resolved diagnostics, BAT or MAT available in your country, then you can do it. If the results are still equivocal, you have to do an oral food challenge test. And if you don't have these tests available, you will consider oral food challenge on any equivocal result. Please do not do the following tests. Some of them have increased risk of systemic reactions, such as the intradermal testing. There is a battery of tests with insufficient evidence that they can diagnose food allergy. And of course, IgG tests have no merit as responses are due to normal immunologic memory rather than allergy. To summarize, overdiagnosis of food allergy has negative health effects, the same as underdiagnosis. The clinical history is key for an accurate diagnosis. Applying 95% positive predictive cutoff values can be useful because not any detectable level is diagnostic. Skin prick test and serum IgE have high sensitivity, while component testing and basophil activation tests have high specificity. Oral food challenges, although they are the gold standard for diagnosing food allergy, they are time-consuming and carry the risk of acute allergic reactions. Proper allergy testing, supported by the history, can aid the diagnosis and may reduce the number of necessary oral food challenges. Still, the best tool to investigate non-IgE mediated food allergy, such as FPIES, is through elimination challenge testing. Thank you very much indeed for listening and your participation.
Good afternoon, I'm Professor Graham Roberts. I'm a paediatric allergist, pulmonologist. I work between Southampton and the Isle of Wight in the UK. Today I'm going to talk to you about food allergy, and I've been asked to focus on current treatments and then looking ahead. So I have a few disclosures. I have research funding from a number of groups, in particular on some food allergy trials from Food Standards Agency and Action Medical Research and the NIH. Also the author of the IACI Food Allergy Guidelines and president of the British Society of Allergy and Clinical Immunology. So what I'm going to cover today is firstly thinking about trigger avoidance and rescue therapy, and then move on to immunomodulation, both specific and general, and then think about what treatments might be available in the not too distant future. So trigger avoidance. So the thing about allergy is once you've identified what triggers reactions, in theory, you should be able to avoid that, in this case, food allergen, and not have any problems. Of course, avoiding food is a challenge, and we'll come on to what happens if you have a reaction next. But let's just think about avoidance first of all. So there's a few key steps needed here. First of all is an accurate diagnosis, and a lot of the information is in history. You need to be take a very clear history, and then order the right sensitization tests, be they skin prick tests or specific IgE, and that should hopefully confirm your history. There may be foods though that you want to exclude, and that might help exclude them. So we now have allergen components that have a lot better specificity for food allergy, and these can be very, very useful when they're available. And a good example is peanuts with the RH2 or 1, 3 and 6 at times, depending on the region. Of course, if it's not clear what's going on, you need an oral food challenge. So once you know what the trigger allergens are, then the next thing is education for the patient and the family. So trigger allergens, what threshold? Some patients are absolutely fine eating, say, baked milk, whereas raw milk will cause a reaction. Important that patients know about cross-reactivities, where specifically to look for hidden allergens, and also cofactors when they are important. So this is all helped by accurate food labelling. And at the moment, I suggest that actually our regulations and legislation around this are not terribly friendly to the allergic consumer, and they need to be clearer, and the labelling needs to be authoritative. May contain labelling where actually there's at times very little chance that actually there is an allergen in the food is really unhelpful for the allergic consumer. So, and that brings me on to allergen and allergy education for the food industry. Absolute mess. So food producers, stores, restaurants, their staff need to understand about allergy. They need to understand the consequences and understand their responsibilities around the allergic patient. We need to do that to enable them to give a better service to our patients. I've put a few references at the bottom which further reading which goes into these. So, as I've already said, avoidance is never going to be 100% effective. There's always going to be accidental exposures, and it's really important that patients and their families recognise those and know how to manage different sorts of reaction. So again, education for patient, education for the family. They need to be recognise different presentations and their severity and know how to manage those. Minor reactions may just need some antihistamine. A more severe reaction involving, say, breathing issues will require some intramuscular adrenaline. Then your patient needs to be prepared to manage allergic reactions. So hopefully they've had some training in clinic, but then they need to have the appropriate rescue medicine, be that adrenaline, auto-injector, antihistamines. With some patients, that might also involve some inhaled salbutamol as second line to the adrenaline. Then, are they able to actually deliver that therapy in practice? Think about a teenager. They're out with their friends. Are they prioritizing their health? Are they actually going to use their auto-injector, not disappear into the toilets when they're having a reaction? So prioritizing health, confidence to make a decision to use some treatment during the reaction, and having a capability actually using that treatment, particularly auto-injectors. And I want to flag up needle phobia in this circumstance, which is very frequent. So then, of course, your patient needs to be able to ask for help, and they need the capability of asking for help. So, for instance, do they have a mobile phone? So, there are some patients which, well, actually a lot of patients where actually they're very good at avoiding the food. They know what to do if they have a reaction. Actually, the food allergy is very well managed. For other patients, though, they have impaired quality of life, quite often associated with ongoing reactions, but sometimes it's stress, it's anxiety about having a reaction that's the issue. And this is where we need to think about, are there other options? And we do have some other options now. So one of them is oral immunotherapy. This is where we have the best effectiveness evidence, and this is a figure from a recently published systematic review we did looking at OIT. In this case, it's peanut allergy, and as you see, there's a substantial risk of the substantial increase in the amount of peanut you need to have a reaction. A lot of heterogeneity between studies though. So we now have one licensed product here, but this doesn't tell the whole story because actually OIT does give rise to side effects, allergic side effects. Sometimes they can be serious with respiratory reactions. But you got to, for some patients, actually, this is the right thing to do. And let me give you an example of a patient who say they have a lot of anxiety around their peanut allergy. For them, taking some OIT every single day at the same time, if they have a reaction, they're in a controlled environment and they can manage that. That may be better for them if, when they go out with their friends in an uncontrolled environment, they know that they're not going to have an accidental exposure to peanuts and have a severe allergic reaction. So for some patients, OIT is a very good strategy. For other patients, it may not be an optimal way of doing things. Again, got to balance benefits and adverse effects. There are some other specific immunomodulatory approaches that in the wings. So epicutaneous immunotherapy, large number of studies have looked at this. There is an increasing reaction threshold to, say, peanut, but less than with OIT. But my reading the evidence is actually there's less systemic allergic reactions. So less effectiveness, but safer. And so that might be helpful for some patients. No licensed product yet, though. So the other thing that's a little further away is a sublingual immunotherapy. Limited evidence at the moment, but what there is shows efficacy, albeit again less than for OIT. But the advantage here is, again, minimal adverse events. So specific immunomodulation at the moment in food allergy, OIT is where we have evidence. But we do have little evidence outside peanut, egg and milk at present. So with the advent of a licensed product in the UK, we all sat down to think about how we could actually implement it into the UK medical system. And this is the document we came up with. We went to a panel of experts. We also talked to a lot of patients and the families as to think about what an implementation framework might look like. Things we thought were important to consider is whether you'd actually need a baseline peanut challenge to demonstrate peanut allergy. Shared decision making with your patient and the family, and good communication. Need to think about compliance. Is your patient going to comply with the daily dose of treatment? Are they happy with auto-injectors as asthma controlled? Really important to have trained staff and senior staff because, as I've already mentioned, anaphylaxis is a potential side effect of immunomodulation in this situation, and some way of rapidly responding to patient queries because they occur. Finally, you need an exit strategy. What happens after a few years down the line? Does the patient progress to real world peanuts? If they're a teenager, you've got to think about transitioning into the adult service, which in the UK and I suspect in many countries is not set up for food allergy immunotherapy. So the other option now in some parts of the world is biologicals, omalizumab. This is the outmatch study which demonstrated in a randomized double-blind placebo-controlled trial that actually you can massively reduce massively increase the threshold for a reaction with omalizumab to peanut and a number of other foods in this trial. This is the pediatric and adolescent data. Safety here looked very good, just a few injection site reactions. So this is licensed in the US. Hopefully it might be licensed in other countries and may well be a consideration if you think about starting omalizumab or another biological for severe asthma. If they've also got multiple food allergy, you might want to think about. So what might be around the corner? Well, a few of these I've already mentioned. So epicutaneous immunotherapy, sublingual immunotherapy might be more appropriate than OIT for patients who are concerned about the side effects and don't mind too much about their lower efficacy. Combining omalizumab and immunotherapy looks like an interesting approach, and that might be helpful, might get you up to a maintenance therapy in OIT that can be continued. And of course, there's that endless series of biologicals that might be assessed in food allergy. Not all of them are going to work, but some of them might be helpful. Finally, the other thing on the horizon has to be other adrenaline administration routes, nasal or sublingual. If we can demonstrate that there's good plasma levels, particularly when experiencing anaphylaxis, they really do have a potential to revolutionize our approach to rescue therapy with patients with food allergy. So let me summarize. Really important, make an accurate diagnosis, identify cofactors, and educate your patient and the family. Education and training absolutely crucial in food allergy. If there's ongoing issues, impaired quality of life, there are other options that now can be thought about, so oral immunotherapy or omalizumab if it's available, either as an indication for food allergy or potentially if there's coexisting severe asthma. There's still substantial research needs in this area, though. We really do need to know the optimal approach to education and think about how to make immunotherapy more practical and understand really where biological therapies are of value to our patients. Thank you very much.
Good morning from Santiago. It's my pleasure to participate in this webinar and share with you some reflections on the patients and physician partnership in food allergy management. It is important to establish a relationship of trust from the first consultation. We must have enough time to question, listen, and register. The migrant population has different consumption habits, and they introduce new foods, especially plant food, in their countries of residence. About symptoms, do not forget that subjective symptoms are difficult to identify in infants. Uncontrolled asthma or atopic eczema are comorbidities with an increased risk of anaphylaxis. The overcoming and also the maintenance of a food allergy must be documented, and also the results of an accidental ingestion. The factors involved in the study of food allergy must consider the severity of food allergy reactions in the study design, consider emotions, fear, and needs of patients and their families, the exams availability, the cost of exams, especially component results diagnosis, health team experience, allergists, emergency service doctors, nurses, nutritionists, psychologists, review of exams provided by patients and their temporal relationship with clinical reactions. For example, a very early prick test after an anaphylactic reaction may have a false negative result. It is not strange that patients have undergone non-validated tests, bioresonance, and others. Oral food challenges are an opportunity for shared decision-making according to the dietary preferences of patients and families, and also the importance of the food. Avoidance of causal allergens goes hand in hand with an appropriate nutritional advice, especially in patients with multiple food allergies. Patients should know their nutritional options, avoidance diets, and they should be educated on food allergy labeling, cross-reactivity of food allergens, and food allergy management outside the home. Other important points are the identification of patients in risk of anaphylaxis and the prescription of adrenaline autoinjectors and the proposal of immunotherapy and preventive measures. Here we have a recent proposal with a three-step approach to shared decision-making on food allergy management. First step, let's discuss this together. A two-way communications between patients and physicians, and they need to listen actively to patients. Step 2, let's examine your options, the benefits and risks of options, and available choices and alternatives. And step 3, time to make a decision if you are ready. With key points, reaching the right decision for each individual patient based on their goals, preferences, and values. And what about emergency treatment? We must consider the episode-related factors as the prompt response to a single dose of epinephrine and the resolution of symptoms, and patients' factors, the immediate access to more than one dose of epinephrine, able to use epinephrine autoinjector device effectively, has a good understanding of when epinephrine should be used and what the benefits are with regards to early use. Immediate access to other people who may provide help is also very important for patients and their families. And what should we communicate about food immunotherapy? Its benefits and risks are, and limitations. The most clear benefits are the increase in the thresholds of reactivity, the protection from accidental exposures, the decrease in the severity of allergic reactions, and the improved overall quality of life. Risks and limitations are the frequent, mild, and moderate allergic reactions during therapy, 15 to 20 risk of anaphylaxis during therapy, a risk of developing eosinophilic esophagitis. The limitations, a 2-hour window after dosing when exercise is not allowed. Certain external factors, illness, tiredness, sleep deprivation, menstruation, hot showers, may lower the threshold of reactivity to dosing. Therapy needs to be taken regularly, long-term, in order to be effective. Although most individuals will become desensitized, a small proportion only will achieve remission and outlive consumptions. What question does a family ask without a formal medical training? Families need to feel safe in appropriate dose and introduction and on recognitions and treatment of the allergic reactions. Some key messages for patients and their families are: oral immunotherapy is an elective, rarely curative procedure with inherent risks and challenges. This procedure requires families and patients to assume the role of amateur medical professionals. Counseling and shared decision-making approaches are required to prepare families for this role. Some key elements of discussion during the counseling and consent process are the type of immunotherapy, oral or sublingual immunotherapy, the use of biological therapy, the improvement in the quality of life, the potential risk as eosinophilic esophagitis, the contraindications, the risk mitigation approaches, known cofactor management, epinephrine adrenaline autoinjector carriage, a long-term discussion and clinical support, and potential for changing protocols and evolving data. Also in the scope of interactions between patients and physicians, with some other key methods, shared decision-making represents a patient-centered approach in medical decision-making individual patients' preferences and needs and values, and children should be encouraged to participate in this process. Although mandatory screening and testing infants before allergenic solid introduction is no longer recommended, some parents may not be willing to introduce allergic solids without testing due to fear and anxiety about allergic reactions. For these families, this approach will likely be on benefits. Decision aids are tools that assist and support patients during the shared decision-making process by supplementing the patient's physician interaction. There are several food allergies that are not overcome in childhood or that begin in adult life. At every step, the experience and empathy of the health team are crucial. Contact with teachers and co-workers of patients is very important to achieve a better protections. Patients' associations can be of great help in educating food allergic patients and their families. These associations also need an appropriate training. There are also some recommendations for traveling. A travel container with all necessary medications, including epinephrine auto-injectors, to remain with the person at all times. Allergen information translated into the foreign language of all destination patients. Non-perishable allergen-free food items must be with the patients. Copies of their emergency action plan also is crucial. Written information that includes a telephone number for emergencies and the location of the nearest emergency room. And here are some pictures of the recognition ceremony of our division. As World Allergy Organization Center of Excellence, we were introduced to apply by Dr. Emilio Alvarez Cuesta, Chair of the Drug Allergy Committee, and after approval, Dr. Ignacio Anzotegui, President of the World Allergy Organizations in 2019, came to Santiago for the inaugurations. Well, thank you very much for your attention.
Why everyone should be educated on food allergy? Well, this was not true years ago. Once upon a time, food allergy was a completely unknown. Allergy was a sort of white elephant where nobody were aware of. But in the last decades, allergy has been growing not only for respiratory, but in particular in the last 20 years for food allergy. Food allergy can manifest itself in several different ways. The first is not severe reactions as oral food allergy or oral allergic syndrome in general due to fruit. So this is something curious and okay, someone or everybody should know it, but this is not so important. However, when food allergy appears with anaphylaxis and sometimes with severe anaphylaxis, then everybody should be prepared to recognize it and afford it. If you just digit data from food allergy in Google, well, you find a sort of a spoon river or food allergy, indicating that food allergy is requiring a heavy toll of young, healthy lives every year. Sometimes food allergy manifests with dermatological issues or with gastrointestinal issues. So everybody should be prepared to recognize food allergy even under these manifestations. The most insidious gastrointestinal food allergy is FPIES, food protein-induced enterocolitis syndrome. This food allergy manifests with symptoms not immediately, but after some minutes of hours after the ingestion of foods. And according to recent data, we have a significant proportion of population in the world that is suffering from FPIES. Of course, this is not so significant as the population suffering from anaphylaxis or severe IG-mediated food allergy, but everyone knows someone with FPIES now. So it's so important that people know it, because recognizing it is the only way to prevent it and to treat it. Who should be aware of food allergy? Which are the person categories that in particular should be aware of food allergy? Well, the first category is the category of parents, because food allergy is often a pediatric disease. This child with an immediate reaction to egg is displaying anaphylaxis, and the mother should be prepared to treat it. In general, the mothers are very well prepared to prevent food allergy because they are choosing their foods, the foods for their babies, very, very wisely. But due to the fact that not in every country in the world there is a legislation regarding the content of food allergies, and practically nowhere in the world there is a legislation assessing the food contamination, that is the traces of foods, well, this makes all the mothers, also the better knowing mothers, confused, unsure, perplexed in front of a problem that is difficult to afford. It's noteworthy to observe that the same feelings are experienced by the patients when they are looking for foods, and they are avoiding foods that they think to pose some danger for them, identified with the foods that could contain, may contain, are produced in a factory that also contains milk, egg, peanut, hazelnut, and so on. And the same perplexity is shared also by the legislators, as while in 100 countries in the world there is a legislation regarding the process of food allergens content as ingredients, in practically no country do exist a legislation about the precautionary allergen labeling, indicating that every producer is free to pose an indication of danger on their products that could be contaminated by milk, egg, hazelnut, peanuts, while they actually are not. This made the legislators also perplexed as the mothers. So the result is that we don't have legislation. Another category that should be very aware of food allergy is the category of doctors, in particular some specialists. For instance, dermatologists, they should be aware that many of the symptoms on the skin can be due to food allergy. Gastroenterologists should be aware that symptoms in gastroenterological diseases can be due to food allergy. Emergency room doctors are in particular in first line on the most acute manifestations of food allergy, due to the fact that in the recent years, the emergency department visit for anaphylaxis are increasing. And this is true in particular in infant and toddlers, where the emergency department visits are doubled between 2006 and 2015. Due to these reasons, doctors are in the first line in food allergy. Another category that is interested in food allergy is the category of teachers. Food allergic reactions may happen in schools due to inadvertent contact or ingestion of foods, and teachers must be prepared to recognize and afford such reactions. Another important category is the category of cook operators, because they may be responsible of severe or less severe anaphylactic or allergic reactions to foods when they are contaminating their foods or not declaring correctly the content of their foods. The food business operators is another category that must be aware of food allergy and must be informed of that. They are responsible for transmitting the correct information about food allergen contents, not only in fresh foods, but in particular in prepackaged foods that can pose some risk to some patients. World Allergy Organization put in place an initiative that is ACT UP in order to solicit the legislators to legislate about precautionary allergen labeling in order to reduce the phenomenon in prepackaged foods and to restitute to the patients the possibility to eat something that they had not consumed, not allowed to consume it so far. This is only one of the initiatives of World Allergy Organization for Food Allergy. We have other initiatives, for instance, guidelines, for instance, suggestions for doctors and continuous educations. And we are continuing to advocate for food allergy awareness through congresses for doctors, through initiatives as the World Allergy Week for everyone in the world. So we hope through our action to get every person in the world aware that their neighbors, their son, their father, their mother can be allergic persons and should be recognized and treated when necessary. Thank you for your attention.
So I will be the moderator for the discussion that will follow. I want to thank each of the speakers for giving an excellent presentation. And we have a panel of experts. And so the way this will work is I will ask the question to one of the speakers, but I'm really asking the question to a panel of experts. And so as I want to have a discussion of these points that people have asked about. And again, I want to remind everyone that if you have questions, to put them into the questions section of the website, and I will see those questions. I will reread the questions so that everybody can hear it. And then again, I will ask an individual speaker, but we'll ask all of our experts to opine on our areas. I do want to take, though, the moderator's prerogative and answer the first question myself. And there's a question about epinephrine, and I really think this is more of a world allergy question than a question to any of our individual panelists. And the question is auto-injectable epinephrine available everywhere in the world? And the quick answer is no, it's not. But the better answer, or the longer answer, is your World Allergy Organization is advocating for having epinephrine around the world and having auto-injectable epinephrine around the world, and is trying very hard to show people why it's important to have epinephrine immediately available for a reaction. And so with that, I will ask the first question to Dr. Fiocchi, and I think this is really a good question, and that is, what is the value and how do we best use our patient advocacy organizations?
This is a question with several aspects, because it depends on the type of organization, the type of country, and the type of health organization in the country. In the universal health system, as is the Italian system, for instance, there is room for patients' organizations in the decision points of some levels for food allergy, and they are very helpful. In other systems, I guess that the role of the patient organizations can be multiple. The first role is to collect and support research. So research organizations are diffused in the world, and they support the research very widely. The second role could be to raise awareness of food allergy among the general audience. And the third role is to empower their members to be fit, ready to respond to the problems of food allergy in every situation. So I see a big role for cooperation between patients, patient organization, doctors, legislators, and all the stakeholders around food allergy.
I think this is a critical question. Are there any other members of our panel that would like to comment on this particular question? Hearing none, I'll go to the next question, which is a question that, oh, I'm sorry, Graham.
So I was going to add onto that a lot of physicians are very pressed for time, and there's only so much time we get to talk to our patients, and quite often families have a lot more questions than we have time to answer for. So I think there's a real role for patient organizations to work hand in hand with physicians to actually help inform families, adult patients, etc. And in the UK, we're very lucky. We have a number of organizations. They have good information on their websites. I know other countries are in that situation, but I really think it's we need as healthcare professionals to talk to and work with our patient organizations to just help them to deliver the information that we might not have time to do in clinic.
Excellent. So the next question is for Dr. Venter, and the question is, can you elucidate some of the reasons, some of the rationale for the difference in prevalence between kids that are in the rural areas and then in city areas? Do we understand this phenomenon?
Yeah, I think that's really an interesting question, and I'm sort of like just borrowing the knowledge I got from listening to Mike Levine in the past. The interesting thing was that the children in the rural areas had higher rates of sensitization to food allergens, even though they had lower rates of clinical diagnosed food allergy. And so Mike always have these beautiful slides where he actually, and I've actually seen that myself also growing up in South Africa, where these children literally live in a house with the chicken under the bed and the dog in the room and the goats walking around and having contact to cows. And so we really think that it is the environmental exposure and probably changes in the microbiome that has the protective effect. Nonglan Lunyani and Liam O'Mahony has also published some really nice data looking at the microbiome of the children in the rural versus the urban areas. And so it really seems to be the environmental factors and sort of like getting back to the hygiene hypothesis that downregulates the clinical allergy we see.
Any other comments or from the panel?
Yes,
If not,
hello, this is Margita Worm from Germany, Berlin speaking. Hi to everybody. Yeah, I just wanted to add to what Karina said. I mean, we know for a long time that the microbial exposure, but also other lifestyle factors which are different between people living in rural areas versus in large cities. So the number of kids in a family, the nutrition, these are also external, or we call it these days the exposome, yeah, is different, completely different in rural versus city areas. So that's also not only for inhalant, but also for food allergies, probably the key mechanisms behind it.
Yeah, and if I can add, so as a dietitian, I should have said that first. There was also differences in ultra-processed food intake in the rural and urban children, as well as advanced glycation end product intake. So the foods, the products we produce in food when we make like barbecued foods or toasted sandwiches. And so not just environmental, but also dietary differences.
Yeah.
Dr. Hosny, there's a series of questions for you, and I'm going to try to combine these questions into one question. So if my English grammar is not quite correct, it's because I'm trying to combine all these ideas. There are several questions about the food challenge test and what the main risks are, what what it really gives us in terms of information. And the question is, what is the success rate? And is it only for diagnostic purposes? How does the oral food challenge help us?
Well, it's really the gold standard for diagnosis, because when you have a reaction on the spot in front of you in hospital or in your office, you will definitely say that this child or this patient has this food allergy. But it's not without risk. There is a risk that the patient can go through severe allergic reaction. And also, there are a little bit difference between ingesting the food in the real life, in the community, and ingesting it in the hospital in a different sort of condition. There is an anxiety. It needs trained personnel, which is not available in every hospital. You have to keep the patient for a while in your office or in the hospital, and this is not always available. Of course, the anxiety that is felt by some patients can lead you into a problem of overdiagnosis. That's why sometimes we have to use the double-blind placebo-controlled test, which is more expensive and more difficult. These are problems with the challenge testing. Myself, I perform a lot of oral challenge testing. Especially that my patients are children, so I can do open challenge test. I don't need to do any placebo or any blinding, but it is not. But it makes me nervous a lot, and I have to have the epinephrine in hand, and I have to be ready for any risk that can happen. Nowadays, we have other alternatives that would decrease the possibility of using the oral food challenges. For instance, if we have in our country a basophil activation test or a mast cell activation test, it would help. It will decrease a little bit the rates of doing the oral food challenge or component testing. But to tell you the truth, many parts of the world do not have this in hand. We only have the skin prick testing, the specific IgE, which are more sensitive than specific and can lead sometimes to over-diagnosis. That's why in some parts of the world, oral food challenge is still respected and has to be used.
I'm going to follow that up with a question about prick testing with There's a question about the value in the utilization of prick testing for things that we don't have commercial extracts for.
Yes, it is very practical to do the prick testing because some extracts are not available or they do not match actually the allergens in a certain country. You know, the food products differ from country to country. Sometimes we have to use the prick testing, especially with the vegetables and fruits and patients with the food pollen syndrome, and it gives very good results. It gives us, we tried it a lot and we use it on daily basis. It is very practical, I think.
Yes, we are also using it quite a lot, and it is helpful because most of the commercial extracts are, the quality, so to say, is limited. There are some exceptions, and also the variety is very limited. But I wanted to add that one has to be aware that non-qualified extract also means that unspecific reactions can occur. So, for example, if you use strawberries or pineapple, you can get unspecific reactions. So, physicians, if they use native material, should be aware and should really know that there are some extracts more often leading to unspecific reactions. And I would also like to add on the double-blind placebo-controlled food challenge. Sometimes it's also used when, for example, children have a confirmed food allergy, but we know, for example, milk or egg allergy, they can become tolerant. So it's also sometimes used to see whether tolerance has occurred. That's also an indication. And the last thing is to determine the dose, the threshold dose, when the kid or the adult is reacting.
There's a question about the multidisciplinary methodology of food allergy, and I want to direct this both to Dr. Worm and to Dr. Venter, because the question has to do, there are several questions. One with how do we involve the family to help the quality of life of an individual who is food allergic? And then specifically for Dr. Venter is what's the role of the dietitian in the treatment of patients with food allergies?
I will let Dr. Worm go first. Or I can talk about the role of the dietitian, because it sort of like touches on quality of life, but I know Graham has done a lot of work on that as well. And I think, you know, having worked in England and now in America, I think there's very different roles for dietitians. So I think it really depends on the comfort level of the allergist and what the allergist expect of the dietitian. So in the United Kingdom, you know, where we have many, you know, dietitians trained to specialist level, and dietitian can become a consultant allergy dietitian. We can actually order tests and interpret tests and help with diagnosis. I was much more involved in actually carrying out oral food challenges. It's very different in the United States, where I don't get involved with testing, interpreting testing, or oral food challenges that much, other than planning the challenge protocol. I've spent my life calculating challenge dosages for FBI's challenges. And so, but really the role we play here in the States is really monitoring the growth, monitoring the nutritional intake, decide about an appropriate substitute infant formula. As Dr. Fiocchi will know, we've done so much work with that under the DRACMA guidelines. You know, any other supplements that may be required. We talk about, cross reactions. So I would always go and ask the allergist, what do you want me to do with the other tree nuts? If we have pollen food syndrome, I'd say, what do you want me to do with the cross-reacting fruit and vegetables? May contain is a tricky one. I go to every allergist I work with and say, what do you want me to do with this family in terms of may contain and all the other forms of precautionary advisory labeling? And now that we have the oral immunotherapy, and particularly following on from the OUTMAT study with beautiful paper from Marion Groach, I'm much more involved in calculating doses for oral immunotherapy, looking at different forms of food with the same allergen dose that the child may want to eat. Think about possible vehicles for that. If we do double-blind challenges, I'm involved in the blinding as well. Otherwise, I just do challenge dose calculations. So I really think we have a very wide role in terms of making sure the diet's nutritionally sound, working with something that works for the family rather than just handing out a pamphlet or a booklet. And then, really involved in the OIT process as well as oral food challenges. I hope I summarized that well. But I really think, some of my allergists would give no nutrition advice. The minute the patient comes in, they'd say, Karina, we need you. Other allergists would like to do some of the nutrition advice and, just let me do some bit. So I work with every allergist according to what they prefer.
Dr. Worm, do you want to comment on that?
Yes, I am. I can say that my experience here in our hospital is that we have a very close interaction with our dietitians, and they are so important because they can really counsel the patients for details in daily life. I could as a doctor not do this, so we have a very close interaction, and but I do know that overall, not all hospitals or other clinicians have. But the point is, you need an experienced dietitian. Yeah? So experienced in allergology, and that's actually even in Germany, there are not so many around. So I recommend, yes, if you have dietitians, get in touch with them, and if they are trained in allergy, very good. If not, support to get them trained.
Any other comments here?
We do have an online course through Food Allergy Research and Education Fair, and we're actually starting our new course in September. So fully online, we do it early mornings for the people in the world that it's like 8 hours ahead of the mountains, and we do later in the afternoon too. So if you have a dietitian, we train them extensively for 10 months in food allergy.
Dr. Fiocchi, you had something you wanted to say.
3 words. Karina, we need you.
There's
many more.
Dr. Hasni.
Actually, we cannot work without the dietitian team in our hospital. We need them in every child with food allergy to aid us in the supplements to be given and alternative foods. So we work as a team actually in our unit, and we have a very good dietitian team.
We have and Dr. Hasni, this is really for you. We have a fairly specific question that I think makes a really good point. And the question is in regards to the safety of a food challenge in a patient with anaphylaxis to shellfish, and who then goes on and has positive skin testing to crustacean shellfish, but negative to mollusks. And is it safe to challenge that patient with non-crustacean shellfish, and specifically here with using scallops for this patient?
I wouldn't do it actually, because I have a good evidence from the history and from a testing, from a skin prick test wheel size with shellfish. I think the reaction is going to be significant. So I wouldn't do it. Maybe after the era of omalizumab and so, in these cases, maybe I will have the courage to do it. But I don't think there is an indication if I have enough evidence that the child is allergic to shellfish. By the way, seafood is one of the important allergens in my country.
There's another, why do some food allergies start in adulthood and not in childhood? I'm not sure I could answer that question.
Could be, actually could be the type of this allergen. Maybe this adult has lost his tolerance, or he wasn't exposed enough in childhood to this food, or maybe they were afraid to give him the food in the first place, such as peanuts. Sometimes parents are scared to start the peanuts early, and that's why the incidence has increased. And we have known that early exposure nowadays, we have experienced that early exposure gives protection. So this could be maybe a new allergen has been for the first time introduced in an adult.
Go ahead, Graham.
What happens in adults is very different to what happens in children. So in children, there's a failure to develop tolerance. So you get a child who may become sensitized and then develop clinical allergy without having seemingly ever ingested the food. So failure to tolerize. Adults, I mean, there's so many examples of adults that they're eating a food and then they become allergic to it. So that's actually losing your tolerance, possibly a completely different mechanism. So, I mean, some of it we understand. So sort of food pollen syndrome, where you are allergic to so in the UK, it's usually birch pollen, BET-V1, because that cross-reacts with the fruit. You then start to develop symptoms with fruits. And that's, you could describe that as a breakdown of tolerance, but through a secondary allergen. I think it's really interesting, and I think there's an awful lot of work that needs to be done with adult food allergy and the pathogenesis leading it onto its development. And I suspect a lot of it's going to be around things like BET-V1. I mean, the other molecule I could mention would be liver transfer protein, where you start reacting to something else and then suddenly you're reacting to a widespread number of foods. But deserves some more work. It's taken us 25 years to work out how kids develop peanut allergy and come up with a solution. It might take us 25 more years to answer the adult question.
Alessandro, the next question is specifically for you, and the question is, where are we heading with cow's milk allergy?
Oh, that's a not easy question to answer. There are some new. First of all, this is an evergreen. Cow's milk allergy is quite stable, probably not increasing, but still a big problem, particularly because this is a staple food for infants, and it happens in particular in infancy. The new acquisitions that are in the last years are several. The first new recommendation that is important to know for the practicing clinicians is that if a baby is cow's milk allergic and she is breastfed, you must not in general take out the cow's milk from the diet of the breastfeeding mother. That is different from what we did in the past DRACMA guidelines and the other guidelines. This is of importance because this does not cause milk allergy to detract to the rate of breastfeeding and to acceptability of breastfeeding to the mothers. The second important news from the very recently published cow's milk substitute guidelines is that quite surprisingly, the same decisions for a cow's milk substitute can be taken in IG-mediated and in non-IG-mediated cow's milk allergy. In the past, we used to use, for instance, more cow's milk hydrolysates in IG-mediated than in non-IG-mediated cow's milk allergy. We considered the use of soy formula in IG-mediated and non-IG-mediated milk allergies, but at the new meta-analysis, there is no reason to do these choices. So faced with a baby with cow's milk allergy, both the allergist, the pediatrician, but also the dermatologist or the gastroenterologist should give the same answer to the similar question. This probably it's important to underscore that pediatrics is one science with, of course, personalized solutions, but in general, the background is similar among the different subspecialties.
Thank you. There's a question. I'm sorry, go ahead.
Can I add to that, because that's my little hobby? I think, one of the other things, we couldn't address it in the DRACMA just because, you cannot do a systematic review with what we know about milk ladders. But I think, we need to make ladders safer. Often ladders are blamed for, fatalities and severe reactions. And it's not the ladder, it's the fact that, we need to know how to use the ladders, and also we need to standardize dose and allergenicity. We're working very hard to actually look at the beta-lactoglobulin, the casein, and the total protein content of all the different foods in ladders. So I hope that that would be something that 5 years from now we will look back and we've got some safe ladders to use safely in all kinds of milk allergies. So that would be my addition.
So it is 9:46. I want to ask the final question, and I've sort of been saving this for everyone to look at or to think about. And the question is oral therapy a good treatment for food allergy? And I think that we can expand on that question and talk a little bit about the future of as we see it of oral immunotherapy. So that's open to everyone from the panel.
This is for Graham.
So can I start by saying yes, for the right patient? I am not convinced that all patients should be having oral immunotherapy. For some patients, I think it's very helpful, very useful, and but it is really important that patients and families understand what it can achieve, what are potential downsides, and where, say, you've got a patient of anxiety, particularly around going out, eating out of the house. I think OIT can actually bring control back to the patient and improve quality of life. But it's a shared decision making. Let's use that and an in-depth discussion, conversation, and you need the family really need to understand what they're getting into.
Yes, I would agree with Graham. I think it's a potential option which requires a lot of time of explanation to the patients, to parents, if you have children, and other surrounding people. They have to be well trained. You need a very good active interaction. And I think we called it immunotherapy. I think that's also something we do not know for sure. I mean, we can increase probably tolerated doses, whether and to what extent really long-term efficacy can be achieved, maybe in subgroups, maybe not in all groups. And I think also the safety management has to be crystal clear in these patients as well.
Dr. Hosny, you had your hand up.
Yeah. To tell you the truth, a few months ago, I wouldn't go for an oral immunotherapy for a child. But nowadays, after the promise given by the omalizumab, I think the future is promising for patients of food allergy. Also, increasing the awareness and education of pediatricians and general practitioners about food allergy will hold many promise in the future. So I think everyone deserves to be treated from food allergy, and this will improve the quality of life of the patients and their families.
A corollary question came in as to how do we prevent food allergies? How do we have primary prevention of food allergies?
This is a very difficult question because we don't have many tools. I believe in breastfeeding. It has some promise in improving the rates of food allergy. But as a primary prevention, I think it's not very much available.
So
I guess lessons we learned from what Graham can better probably is from UK. I think the key studies are from UK about this. What we learned is that the late introduction of food allergens to a diet is probably not solving the issue. So it's rather the early introduction, so by early exposure, and that's the window of opportunity. What is currently thought that if you have an early introduction, you may support the development of tolerance, but so far this has only been shown in some studies in the UK, for example. It has not been shown in Germany, so there are still no changes in the recommendation. So that's an ongoing process, so to say. But like in allergy, in principle, exposure does play a role, and the time of exposure in life is also important. How, when to realize, I guess we are still in a learning process.
Dr. Roberts, do you have anything you want to add to that?
Okay, so I could talk for the next hour, but I'll try and keep myself to 60 seconds. So I was looking at some data from the 1990s when I was at medical school, 1990. So a lot of the British population were feeding their infants solids by 2 months of age, almost all of them by 3, and the rest definitely by 4 months of age. Today, most parents will start feeding their infants solids about 6 months of age. Back when I was at medical school, food allergy wasn't an issue. We weren't taught about it. Now it's a complete epidemic in the UK. We've got to get back to what we were doing in 1990, unfortunately. And that's a challenge because we've now got a mindset of late weaning. There's good data from the UK. There's really good data from Scandinavia from the Preventolal study. And Margita, I would suggest there are some positive egg early intervention studies from Germany as well, although there were some challenges with powdered eggs. So I think a main issue is now how to help parents introduce foods into their infant's diet early, complementary feeding alongside breastfeeding, and how to do that. And we're just about to kick off a study in the UK really focusing on that.
I wonder if I can add one thing. Of course, I'm going to say it needs to start in pregnancy because that's all my research. But, you know, I currently have a paper under review. I don't want to jinx it now, where we actually show that if you can address mom's diet and mom has a healthy, varied diet in pregnancy, and you do early diversifying of the infant diet, like Graham said, let's get the food in and let's not be scared of allergens and other food. That's your best combination for reduction, not only in food allergies, but also allergic outcomes. And so we really need to start early, address both mom's diet and baby's diet. And the bottom line is, don't be scared of food, you know, just feed it when mom's in pregnancy and when baby's ready to eat.
So it is now 9:54. We're almost at the end of our seminar, and I do want to give Dr. Hosny as the chair of this year's World Allergy Organization's World Allergy Week a chance to wrap up with some comments of her own.
Actually, I'm so happy to have this subject of food allergy in this year where I had to organize the World Allergy Week, because I'm so much interested in food allergy. We were lucky to have a panel of speakers who are really, really very good experts. So what I want to wrap up is that we have new options now for the diagnosis and treatment of food allergy. An accurate diagnosis is very essential. We have to raise the awareness of physicians all over the world how to diagnose food allergy correctly. History, of course, is the first step, followed by the simple tests that we can do. I would like also to give the point that was discussed by my colleagues today, the early introduction of food. Don't be so afraid of nutritional elements in the diet of the children, and even in the nursing mother. We should not stop the nursing mother from eating anything while nursing her child, because even the amounts that goes in the breast milk are so little to cause a severe reaction. Maybe early introduction of food is going to be a promise for the future control of food allergy in the coming generations. Thank you very much indeed for your participation.
And Dr. Hosny, thank you for chairing this. To all of our speakers, thank you so very much for outstanding presentations. And to our audience, thank you for your time and attention. This concludes this year's World Allergy Week.
And happy birthday to our president, Bryan Martin.
Happy birthday, Bryan.
Happy birthday.
Happy birthday.
Happy birthday.
Thank you.
Ciao.
Bye-bye.